What we saw when we looked at the 1-year result and then at the 2-year results is that transcatheter aortic valve replacement remains very favorable and has very favorable outcomes when you compare it to surgical aortic valve replacement. If we look at the primary outcome, which was all-cause mortality or disabling stroke, that occurred in 4.3% of the patients who had a transcatheter aortic valve replacement and 6.3% of the patients who had a surgical aortic valve replacement. So that p-value doesn't meet statistical significance there for superiority. The p-value is 0.084. There's a 2% absolute difference, but certainly there's a slight difference numerically. And when you look at non-inferiority, it's clearly non-inferior with a p-value that's less than 0.001. I think it's important when we're talking about young patients that we understand how they're doing after these procedures. And it becomes not only how are they doing 30 days afterwards or a year afterwards, but 2 years afterwards and further on from that. These are low risk patients who we expect to survive decades at a time. There has been some concerns about surgery catching up to transcatheter aortic valve replacement after the first year. We certainly know that transcatheter aortic valve replacement is less invasive. Its costs on the health system are less as patients stay in the hospital for a shorter amount of time. Cost on society is less. The patients are back able to participate in work. A lot of these patients are low risk, are still working, still active within society, and so it gets them back there doing it. But it's also important that the transcatheter valve have durable results, and it maintain that not just for a year or 2 years, but thereafter. And so, we have data from here looking at hemodynamics and looking at leaflet thrombosis, and we see, again, very favorable results with this self-expanding supraannular valve that throughout its studies with the Evolut system has shown to have hemodynamics that are superior to surgical aortic valve replacement, and in fact, superior to aortic valve replacement when the valve is placed at the annular level. Health systems across the globe, in Europe, in the United States, in Asia, everywhere, have really been stressed. Resources have been strained, hospitals have been filled, and we've looked for ways to become more efficient in some ways. I don't think in patients we want to sacrifice long-term outcomes for a short-term gain or short-term efficiency. But if we can establish both, if we can have short-term efficiency, have patients who need to be in the hospital, often, the average length of stay is a day or two if you've had a transcatheter aortic valve replacement, that allows for greater turnover. It allows us to take care of patients who, let's all be honest, in the past 12 to 16 months, our hospitals across the globe have been filled with patients who have COVID, who have other struggles. We need to be able to continue to treat our patients with cardiovascular disease, but we need to be able to do it in an efficient manner. And certainly transcatheter valve is proving to be that. I think that the take-home message from this is that when we look out to 2 years, transcatheter aortic valve replacement with the Evolut system is doing exceptionally well when you compare it to surgical aortic valve replacement. It's clearly non-inferior. It doesn't quite meet superiority for morbidity or mortality, although there is a 2% absolute difference in terms of the numbers. Now, there certainly are some differences in terms of some of the secondary outcomes. I talked a little bit about the fact that a supraannular valve gets better hemodynamics, and with the better hemodynamics, we get less patient prosthesis mismatch. On the other hand, we do know that surgical aortic valve replacement has been associated with a lower pacemaker rate. And it's also been associated with less mild or greater paravalvular leak. And so what does the impact that mild paravalvular leak have over decades? We'll have to see. And how does that compare to hemodynamics that are better? I think that's why it's really important and critical, and why we are in this study going to follow these patients out for 10 years to really understand the long-term implications that transcatheter valve has. The key here is that there's a heart team evaluating these patients, looking at the CAT scan. Not all patients are eligible for a TAVR. They may have sinus of Valsalvas that are too small. They may have annuluses that are too large, or they may have really bulky and just prohibitive LVOT calcification. So it's important to take each patient individually. If the patient as an individual meets the criteria where we think we could get a very good outcome with a transcatheter aortic valve replacement, then this data would suggest that that's quite a viable and beneficial thing for the patient.